This is a continuation of the lecture series on the blood. I am Professor Queen, your AMP2 instructor, and we will be starting with the white blood cells for this particular video. And your white blood cells. There's a picture of all five different types of white blood cells, and they are the only formed element in the blood that are actually complete. You could see that they all have nuclei, all five types of white blood cells. They also have cytoplasmic granules, they have inclusions, and they have organelles inside them. So they are really complete cells. And they make up, though, only 1% of the total blood volume, and they run from about 4,800 to about 11,000 or less white blood cell per microliter of blood. And the function of these white blood cell will be in defense against disease. They do have the ability to travel from the blood into the tissues via a motion which you call diapedesis. They can squeeze right in between the cells, get out of the blood, the capillaries, and then into the tissues where they are needed. Where do they go, and how are they going to receive instructions as to exactly where to go? Well, they do respond to chemicals. The tissue cells that are in trouble are the ones that will be releasing the chemicals, and they are inviting the white blood cells to come onto their rescue by secreting these chemicals, and the white blood cells walk towards them via the amoeboid motion and a positive chemotaxis towards the chemicals that's produced. So when the white blood cell count turns out to be more than 11,000 per microliter, then you call that situation leukocytosis, where there is an increase in, and usually is a normal response to infection itself. The leukocytes, now let's take a look at the structure. The leukocytes are grouped into two major categories. Ones that are carrying granules in the cytoplasms are called granulocytes, and they are visible on the microscope. These are the neutrophil, the eosinophil, and basophil. And the ones that do not carry any cytoplasmic granules at all are called agranulocytes. Now, white blood cells come in varying abundance also in the blood. The most numerous of all the white blood cell will be your neutrophil, and the basophil is actually the least in number. And there is a mnemonic that you can use. Never let monkeys eat bananas. N stands for the neutrophil, L stands for the lymphocyte, M stands for the monocyte, E stands for eosinophil, and B stands for basophil. So from the top, which is never, the neutrophil is the top in abundance, and the rarest is actually basophil. So you could use this mnemonic whenever you're being asked a question about your the abundance of these white blood cells. So you could see here, your neutrophil accounts for about 50 to 70% of the white blood cell population. Your eosinophil has an average of about 3%. There are not really that much of them. Basophil is 0.5% to about 1%. And among the agranular ones, the lymphocyte counts for about 25% to about 45%, and then the monocytes will be between 3 to 8%. So let's start with the granulars. And the granulars will be neutrophil, eosinophil, and basophil. The granular leukocytes would be larger than the agranular. They are shorter lived than the red blood cells. They contain lobed nuclei rather than circular. The cytoplasmic granules stain specifically with right stain, and all of them, up to a certain degree, are phagocytic. So your neutrophil is right there. Picture of the neutrophil is right there, although this picture here is me, and that's not a neutrophil. So the most numerous white blood cell counts for about 50 to 70% of the white blood cell population. It is twice the size of your red blood cell. And the granules contain hydrolytic enzymes or antimicrobial proteins, which you call defensive. And because of the shape of the nucleus, you call them also the polymorphonuclear leukocytes or the polys. And these polys can have really lots of lobes in their nuclei. Some of them will have about six or 3 to 6 or maybe sometimes 10 lobes, which is a rarity, but it is possible. They're very phagocytic. As a matter of fact, they are called the bacterial slayers. They are the first to run into your defense, into our defense. And of course, they are also, because they are the fighters and they're the first one on the battleground, they do die. They do spend a lot of their energy and they do die very easily. So after them, a group of bacteria, phagocytes, will have to take over. And usually these are the monocytes. But these neutrophils are the first ones. They pretty much like secrete defensive, or they do have defensive granules in their cytoplasm, and they would also be releasing oxidizing substances in a respiratory burst to kill microorganisms. Then you have my favorite, which is your eosinophil. That's really a beautiful white blood cell right there. There are not really very many of them. There's about 3% of them. They are bilobe. They do have very beautiful red colored cytoplasmic granules. They play a major role in allergies and asthma, therefore, and in parasitic infections. Therefore, they increase in situations where you have an allergy or you possibly have parasitic infections. Then you have uh, the rarest of all the white blood cell, which is your basophil. There's only about 0.5 to 1% of them. Therefore, for every 100, you could see only one, or maybe for every 200, one of them. That's pretty much really very rare. It would actually have a deep blue purple granule, and they produce histamine, which is an anti inflammatory chemical. They also produce heparin. They are very similar to an anti inflammatory or a cell in the tissue, which you call the mast cells that produce histamine. So, the agranular ones do not have any cytoplasmic granule, and there's a couple of them. Now, both of them will have spherical, uh, really round nucleus, or it could be kidney shaped nucleus or C shaped nucleus. So here's your one that would be very small. The smallest one of only white blood cell is actually your lymphocyte. And there are two types of lymphocyte, and they both play major role in specific immune response. The T cells are your cytotoxic T cells, known to be like the killer T cells. They act against virus infected cells and also tumor cells. And the B cells are the ones that give rise to the plasma cells or the antibody producers. Then you have your agranular uh, monocyte. Monocyte is usually the largest of all the white blood cell, but there's not really many of them. They are 3 only to 8% of all white blood cell population, and they do have a large nucleus that is C-shaped or shaped like a horseshoe, and it occupies almost the entire nucleus, but you could still see the cytoplasm without the granules, okay? And they leave circulation and differentiate into macrophages. They're actively phagocytic, and usually they take over the battlefield or the battleground after the neutrophil. Neutrophils are always the first one in the battlefield, and they take over in order to help the neutrophils. Okay, and they also activate the other lymphocytes to mount an immune response. So here's all of them, guys. You have your granulars. These are 3 granulars and the agranulars. So now, let's take a look at the production of white blood cell. So just like any blood cell, the great great grandmama of all the blood cell is your hemocytoblast, and therefore, even among the white blood cells, the hemocytoblast is the great mama, which means a stem cell that gives rise to all five of them would still be your hemocytoblast. And the term given for the production of white blood cell is leucopoiesis. And because there's actually five of them, in order for the hemocytoblast really to differentiate into any one of the five, the the hemocytoblast will have to receive five different hormones or growth hormones to prompt it to become either in any one of them. And usually the prompter or the hormones run from, and the interleukins, interleukin 3 or 5, and some colony stimulating factors that helps it to be identifying itself as exactly how it's going to differentiate. So the colony stimulating factors are named after the white blood cell count. For instance, the granulocyte stimulating factor would stimulate it to become granulocyte. Okay, so all leukocytes originate from the great great grandmother, but they branch into two pathways. First pathway is called the lymphoid stem cell pathway. They produce lymphocytes. And the second one is your myeloid stem cell. They produce the rest of them, all other four. So let's take a look at, I'm going to get into the picture that I wanted so much, in this one here, to explain leucopoiesis more. And then, take a look at this. This is actually something that is telling you that it's starting from the hemopoietic stem cell. Now, if there's going to be like a hormone that's going to prompt it and stimulate it, it could become either a myeloid stem cell or a lymphoid stem cell. If it pretty much differentiates into a lymphoid stem cell, then the hemocytoblast is committed to become either one of the two lymphocytes, the B or the T cell. However, if it becomes a myeloid stem cell, it is committed to become any one of the four. Therefore, it would need still to be, again, receive another prompt from colony stimulating factor to become any one of the four. It could be like producing an eosinophilic stimulating factor for it to become an eosinophil, or a neutrophilic colony stimulating factor to become a neutrophil. So here you have two steps of prompting the hemocytoblast to become any one of the four. Right here, it needs only one prompt, okay, for it to be prompted by a hormone that is going to make it become a lymphoid stem cell. And all the way, when it's committed to be a lymphoid stem cell, it can become any one of these two already, depending on where it's actually going to develop. So there are many hemopoietic hormones, and pretty much these are actually used clinically. They can stimulate the bone marrow of cancer patients, and because cancer patients eventually would suffer from the loss of a lot of the blood cells because of chemotherapy, hemopoietic hormones are clinically used to help stimulate, again, re-stimulate the growth of the bone marrow hemopoietic cells. And they also are used to increase the protective immune response of patients with AIDS, because the AIDS virus really kill the lymphocytes, the helper T cells, most especially. And whenever the helper T cells, when we get into the immune response, you'll find out that the helper T cells play a major role in in the immunocompetency of both the T cells and the B cells. A long time ago, when they were actually discovering these lymphocytes, they discovered the lymphocyte T and the lymphocyte B, and then they discovered the helper T cells. That's how they named it to be helper. They thought that it's only a helper to the T and the B. To me now, if you're going to take a look at the real function of the helper T cell, he's actually functioning like the big boss, because whenever AIDS, now that the AIDS virus is here, whenever the AIDS virus is actually attacking the helper T cells, the entire immune system is actually not going to work anymore. So it's actually like not just a helper, it is the big boss. It is supposed to um, get the B cells and the T cells gain immunocompetency. So there are many different types of leukocyte disorders, which I am not going to discuss. I'm going to hold you responsible. I'm going to put this in the exam, starting from your leukemias, okay, or leukopenia, which is abnormally low white blood cell. All right. I am going to go directly into the platelets. A platelet is the third component. It may sound like it is the least, but no, it is not. It can't be. It's actually playing one of the major roles in the physiology of the blood. They are fragments of larger megakaryocyte. They are not complete cells. They don't have any nucleus or anything. Pretty much when you see in the microscope those bits and pieces of amorphic or shapeless uh, of, structures in a screen, those are actually the platelets. They contain chemicals that is serving to help us in a clotting process: serotonin, calcium, enzymes, ADP, your platelet-derived growth factors. These are all in the platelets. So the function of the platelet is to form the platelet plug, which we are going to be looking at whenever we get into the physiology of blood clotting. All right. But if your platelets are not um, if your platelets are not active and they are not needed in any blood clotting, uh, the platelets inside the blood must be kept inactive. Okay, and therefore, the endothelium, meaning the cover of your uh, blood vessels, secrete nitric oxide and prostacyclin, and these are the ones that are keeping the platelets inactive. They are making sure that they don't burst. Okay, so your platelets are formed by another hormone which you call thrombopoietin, and they are formed from the myeloid line from the megakaryocyte, and they pretty much like become the platelets all the way to the end. Actually, it is a very strange type of formation, but once they are formed, they are not anymore going to be true cells. Here's how it looks like. You have your hemocytoblast, the great great old mama of all blood cells. The moment it receives thrombopoietin, it becomes a committed platelet, a megakaryocyte. A megakaryoblast is committed to become a platelet. It will start to divide, okay, and as it is dividing, it is not completing mitosis. There is no cytokinesis. Only the nucleus that you can see here, so you now have double nucleus, will divide. And right here, you have already like four, one, two, three, four, five, maybe six nuclei right here. So until such time that when it keeps on dividing, the cell becomes so big and it cannot anymore handle it, and then it will burst. Okay, when it bursts, when it disintegrates, then it will be releasing those fragments, which you call platelets. Right? So this is a good cheat sheet for blood elements. Make sure that you know that this is available to you in your studies. All right. Now we're going to get into the physiology of one of the functions of platelets, which is hemostasis. Hemostasis is a series of reactions in the blood that would result in stoppage of bleeding, which requires several, about 20 clotting factor. And these are substances that are released in the blood coming from mostly in the liver and the injured tissues. You got them, it's also being produced there in order to stop bleeding. And there are three steps that are involved. You have vascular spasm, you have platelet plug formation and coagulation or blood clotting. So vascular spasm is actually the process of vasoconstriction, meaning the lumen of the blood vessel constricts or it becomes smaller. This is actually triggered by a direct injury to the smooth muscle of the blood vessel, and the chemicals that are released by the endothelial cells and the platelets would also stimulate spasm, and pain reflexes would stimulate spasm. Guys, and that's the reason why, take a look at this. Whenever you are in pain, your blood vessels are being stimulated to undergo spasm or vasoconstriction. That's why people who are in pain sometimes would experience an increase in blood pressure because of vasoconstriction. That's one of the that's one of the reasons why uh, blood pressure rises. And vascular spasm, though, is very effective in smaller blood vessel. It is a protection against blood loss and can significantly reduce blood flow in the area where it is injured in order to prevent blood loss while waiting for the blood clotting mechanism to kick in. So the next step is what you call platelet plug formation. This is where the platelets come together, they stick to one another, but first they are exposed when there is a cut in the blood vessel. They're exposed to the collagen of the tissue that's been cut. And they do magically come together when they stick to the collagen. Um, then they are already going to start to burst. So platelets do not really stick to intact vessels because the collagens are not exposed. But the moment they are cut and the collagens come out, that's it. So how how is the platelet plug formation going to start? Well, you have to have injury. You have to have collagen around. Platelets will get stuck to the collagen, and when activated, platelets would swell. They will become spiky and sticky, and they will release messengers, chemical messengers such as ADP, serotonin, thromboxane. And the more the platelets become sticky, for as long as there is injury right there, it's a positive feedback thing. Your platelets will be releasing more chemicals. They become still more sticky. They pile one on top of each other. And then the pile of platelets get bigger and it becomes a plug. So the platelet plugs are good, really. If you're talking of very fine vessels, then your platelet plugs are sufficient to stop bleeding in that particular area. But if you get shot, and let's say your big arteries are actually shot, and you poke a hole or you cut your big arteries, no amount of platelet plug would help you. You are still going to bleed. You need to put something there in order to stop bleeding. So the third step in the stoppage of bleeding or in hemostasis is what you call coagulation or blood clotting. This is a series of chemical reaction that would pretty much lead to the formation of fibrin or blood clot. Now, blood here are effective in sealing larger vessel breaks. Blood is transformed into from liquid to becoming like gel-like. This gel-like substance is going to be very rich in fibrin. So where did fibrin come from? Well, remember that your blood is actually a connective tissue, a liquid connective tissue, and all connective tissue will have fibers. You probably won't even realize that your blood, whole blood, has fibers, because the fiber in the blood in the plasma is in the form of fibrinogen, which is a very soluble fiber. You don't see it at all. But the moment the clotting factor starts to produce, down the line, starts to produce a particular tissue factor or a particular substance which you call thrombin. Thrombin is the one that's going to stimulate in the fibrinogen to be converted into fibrin. Fibrin now is the soluble fiber that is typical of how we know fibers are. We can see it under the microscope. Then you see it as fiber. That's the fiber of the blood. So let's take a look at coagulation. Coagulation is a series of physiological reaction that leads to the production or the formation of fibrin. There are several clotting factors that are necessary here. They play a major role in the production of fibrin. We number the clotting factor from 1 all the way to 13, all the way to 20. As a matter of fact, they are being produced all over. Most of them in the kidney, in the liver. An example of this is your vitamin K, which is synthesized in the liver. You have also the anti-hemophilic factor, which is factor 8. Okay, you have plenty of coagulation factors, and they occur in 3 phases. All right. So these are the events in homeostasis, and that picture right there is just telling you exactly how it works. But we're past that, and these pictures are helpful for you to be studying it again. We are now into the coagulation, and I would like to pretty much give you a simplified version of the pathways, the 2 pathways that are involved in the production of thrombin. Thrombin, and so that thrombin can stimulate the production of fibrin. Well, first of all, there's actually what you call the extrinsic and intrinsic pathway. Okay, the extrinsic pathway happens, the intrinsic pathway happens within the blood. These are the series of activity that's happening when clotting factors are actually exposed to injury. And then the extrinsic one are actually the ones that is triggered by factors that are outside of the blood, which actually is in the tissue. So these are the 2 pathways. You have the intrinsic pathway, things that are happening inside the blood, and the extrinsic pathway, things that are happening inside the blood. Now, don't be scared with these different factors. And it's just telling you that there is a cascade of mechanism that is happening. Down the line, if you're going to follow through, the end effect of that intrinsic pathway is actually the formation of a very important substance which you call the prothrombin activator. And right down here in the extrinsic pathway, there are also less intricate, but there's still a pathway. Okay, and the end effect is also the formation of prothrombin activator. So between the extrinsic and the intrinsic, there's actually a series of physiological processes that are happening biochemically, and they have one particular end effect, the prothrombin activator. So what is the prothrombin activator? Well, prothrombin activator would be activating the formation or the transformation. It actually catalyzes the transformation of prothrombin to an active enzyme, which you call thrombin. And remember, this is the thrombin I was talking to you about. So prothrombin to thrombin. So the prothrombin, after being converted into thrombin, will now be acting on the fibrinogen, which is the soluble fiber in the plasma, converting the fibrinogen to fibrin, which is an insoluble polymer, and it would altogether be forming the fibrin clot. That is your fibrin clot when you have already your fibrin. So without the thrombin, you're not going to have the conversion of fibrinogen to fibrin. So you need the thrombin. But thrombin is needed in blood coagulation, but should not be in the blood if you do not need your blood to clot. Therefore, the body makes sure that thrombin is not always around, because that is dangerous. Having thrombin around is dangerous, because the moment thrombin, right here on the phase 2 of blood clotting, is released, then thrombin is going to convert fibrinogen into fibrin. You're going to have blood clotting. For as long as thrombin is around, it's going to be converting every fibrinogen it encounters into fibrin. So do you have thrombin? And this is how the fibrin mesh would look like. So for as long as you have thrombin, and hopefully you're not going to have thrombin floating around just freely, all right, you're going to be converting fibrinogen into fibrin, which is not safe, because you are going to be forming little clots. So once your clot has been formed, clot must be stabilized. And clot is actually stabilized through what you call clot retraction. Actin and myosin pretty much would be contracting between 30 to 60 times per minute, and the contraction will pull the fibrin strands closer together. It's just like a net that's being pulled together, and that's going to be squeezing the liquid in them. That liquid that you can see whenever your blood has clotted, and you can see that the blood is already starting to form a scab, and you push it down and you could see some white, clear liquid coming out from a healing wound. That's not plasma. That is what you call serum. Both serum and plasma are liquid portion of the blood, but plasma is the liquid portion of whole blood, whereas serum is the liquid portion of clotted blood. And so what's the difference between the two? They're both liquid portion of the blood. Well, liquid portion of clotted blood would not have fibrinogen in it anymore, because the fibrinogen has been converted into fibrin. Whereas in a whole plasma, that still would have fibrinogen in it because it has not clotted. So, as the blood vessel is starting to heal and clot retraction would occur, another hormone, which you call the PDGF, or a platelet-derived growth factor, is released by the platelets. This would stimulate the division of smooth muscle and cells, and fibroblasts will be called in to rebuild the blood vessel wall. The blood vessel will now be regrowing and regenerating itself. Okay, and this is the start of the healing process. But what happens to the clot? Well, the clot needs to be taken away. So fibrinolysis starts there, all right? The clot will have to be removed as soon as repair starts, okay? And eventually, at the end of the repair, you should not have clot anymore. The top portion of the clot usually dries off and will form what you call a scab, which is pretty much like removable or sloughed off whenever the tissue has completely healed. So there is a very big name that I want you to remember here. One which you call plasminogen. This is a plasma protein that is trapped in the clot itself and is converted to plasmin, which is a fibrin digesting enzyme. So plasminogen needs to be converted into plasmin. And plasmin is actually the one that would be digesting the clot slowly. Okay? And usually the tissue plasminogen activator, factor 12, thrombin, all of these would play a role in a cascade of mechanism in the conversion or in the formation of plasmin. So there are factors that would limit the growth of clot. You do not want clot to be just roaming around. Clot is a special physiological process to stop bleeding, but you do not want clot to be always there, most especially if you don't really need it, if you're not bleeding. And there are mechanisms that would limit the clot that has formed already so that there will be swift removal of the clot. Clotting factors must also be removed. If you have clotting factors circulating around, it will definitely still form minute quantities of clot. So you need all clotting factors to be removed. And there's an inhibition of activated clotting factor in order to limit the size of the clot. And then thrombin, the culprit, thrombin. You form thrombin to form fibrin. That is, thrombin is very important. But for as long as you're bleeding, thrombin is important. But once it is already gone, then you don't want thrombin to be around anymore. So you would like to limit the amount of thrombin. You want to limit also the thrombin that has been released to be just restricted to the clot itself, just where the injury is. The moment the thrombin scrapes out, that's the dangerous part, because when it scrapes out, then it's going to be down the line, going to be converting the fibrinogen just wherever it goes. There is what you call the antithrombin 3. The antithrombin 3 is a factor that would inactivate any unbound thrombin that would escape into the bloodstream. Heparin in the basophil and mast cells inhibits thrombin by enhancing the production of antithrombin 3. So, there are also factors that would prevent undesirable clotting, such as factors that prevent platelet adhesion. Your endothelium has a non-wettable property. It's very smooth. It prevents platelets from clinging on it, and therefore platelets would just slide through it. The endothelium also would secrete antithrombic substances such as nitric oxide and prostacyclin. You have also vitamin E, which is a very potent anticoagulant. And pretty much so, guys, these are preventing undesirable clotting. So these are now disorders of hemostasis, which I am just going to leave to you to pretty much like review. You have your disseminated intravascular disease. You have your thromboembolic condition. What's the difference between a thrombi and an emboli? Please make sure that you know that. And I would like you to also consider knowing for your lecture exam what these anticoagulant drugs are. Aspirin, heparin, warfarin. These are very common anticoagulant drugs in the market. Make sure that you know that. And I'm leaving all of these things to you. Okay? Hemophilia, whatever this DIC is. And we're going to get into something that is probably going to be part of your exam in the lecture, which is blood compatibility by learning the human blood groups, blood typing. You've done blood typing in the lab, and I'm just going to zoom right into blood typing. And blood typing is brought about by the different human blood groups. We have several blood types that are following the ABO system. And then you have another additional blood type with the Rh antigen into consideration. So, between the ABO and the Rh blood groups, in a nutshell, in its simplistic count, we probably will have only like 8 blood types. Okay, so let's take a look at the ABO blood groups. The ABO blood groups is based upon the different types of agglutinogens that are present on the surface of the red blood cells. And there are two different types of agglutinogens. You have your type A agglutinogen, where if it is present in the red blood cell, then that particular red blood cell will be called blood type A. And then you have also the blood type B or the type B agglutinogen. The type B agglutinogen, when present on the surface of the red blood cell, will make your red blood cell blood type B. If you will have both agglutinogen A and B in the surface of the red blood cell, that will make your blood type AB. And if you do not have any agglutinogen A or B, then that will make your blood type O. And in so doing, each of the agglutinogen have a corresponding antibody or otherwise known agglutinin. When you say antibody, it is acting against the agglutinogen or the antigen. Let's say antibody A is against agglutinogen A, antibody B is against agglutinogen B. So in the process of transfusion, your whenever your whenever your blood type A gets to be wrongly transfused into blood type B, then the blood type B person must have something that must be combating or that must be preventing the blood type A from mixing nicely in the blood. And that's going to be the antibody against A or the anti-A. So here is a picture of the ABO blood group. This is your blood type A. This is blood type A. No, it's AB. AB, it carries B. It carries B and agglutinogen, and it carries also A agglutinogen. So here is a blood type B. It carries nothing but agglutinogen A. And here is blood type A, and it carries nothing but agglutinogen A on a surface. And this one here does not carry any agglutinogen on the surface, and therefore this is an O. So pretty much besides the blood type A, B, AB, and O, you can actually have also the presence of the Rh factor on your blood. And the presence of the Rh factor in your blood makes you an Rh positive if you have it. But if you don't have the Rh factor, then that makes it an Rh negative. There are really 52 named Rh agglutinogens or factors, and the C, D, and E are the most common. But for our purpose, we just call all of them. We're not going to be designating it as C, D, or E. We just call it Rh positive when you have it. Okay, and about 85% of people are actually like Rh positive, and a good 15% only are Rh negative. So in your lab, you will learn how to be doing blood typing. And therefore, I am holding you responsible for knowing what the reactions are when you are putting an antibody A into a blood type A or so. And if you have questions on this, then you can actually ask me during our QA sessions. So let's take a look at a homeostatic imbalance, which you call the hemolytic disease of a newborn. The hemolytic disease of the newborn is called erythroblastosis fetalis. And this will happen only whenever there is actually a mother. Okay, let me see if I have a mother here. Nope, no mother here. If you have a mother that is Rh negative and is pregnant with a baby or a fetus that is Rh positive. So what's going to happen if you're Rh negative and you're carrying somebody, okay, that would be Rh positive. That Rh positive carries the agglutinogen, but you, as a mother, you do not have the agglutinogen. Therefore, for the first trimester, all the way into your entire pregnancy, if there's going to be like accidental mixing of the fetus blood into your bloodstream, you're actually exposing yourself into the Rh positive. Now, your being that you are Rh negative, you will now start to synthesize your white blood cell, and your white blood cell now will know that you are receiving Rh positive anti agglutinogens, and will start to produce antibodies against it. And the antibody against it is called the antibody D. So let's say now you you gave birth to your first baby. Usually, this is a very slow process. The first baby, the first Rh positive baby of the mother, usually will remain alive, will be born alive. However, if you become pregnant again, and during your second pregnancy, you become pregnant with again another Rh positive fetus. Now, during the first or second trimester, when there's going to be again accidental mixing of the Rh positive blood into your Rh negative blood, this time around, the process of reacting and producing the antibody against it is not anymore going to be slow, because your blood has been previously exposed to the agglutinogen. The second time around that it's been exposed, it will immediately know already how to produce the antibody D. So the second interaction, the second exposure, the white blood cell can immediately produce antibody D, and that can kill immediately the baby because of the transfusion reaction. Not transfusion, but the mixing of the baby's blood into your blood. So the baby gets killed because of the situation where you call erythroblastosis fetalis, or the hemolytic disease of the newborn. This is where the newborn, okay, the blood of the newborn receives antibodies from the mother that is going to kill, or that's going to agglutinate all of its red blood cells. This happens only in cases of negative, rather Rh negative mothers. But Rh positive mothers bearing Rh positive babies, even if their blood mixes, there won't be any hemolytic disease. All right. If you have any question on this type of reaction, please make sure that you ask me questions so I can answer them during our QA sessions. All right. So I am holding you responsible for looking at transfusion reactions. Okay. Why your type O is called the universal donor. It's called a type O because it's called a universal donor, because it doesn't carry any antigen that's going to trigger any immune response, which means if you donate O to A, because it does not carry any antigenic marker in its cell membrane, it is not going to stimulate any production of antibody against B or A. And even if you give it to an A or a B, or even an AB, all right, no antibodies will be produced because it does not carry any antigenic marker. But AB carries both antigenic marker, but it does not carry any antibody. It does not have the ability to produce any antibody. That's the AB right there. Therefore, the AB, because it does not produce any antibody, can receive anything. It can receive blood with antigen A, or blood with antigen B, or blood with antigen A and B like itself, and it will not be producing antibodies against it. Therefore, AB is called the universal recipient. All right? So, here you go, guys. This is your blood typing. And I'm pretty sure you have this already in your blood. I mean, in your lab. Blood typing, this is actually, if you have a drop of blood, one drop of blood, you put antibody A into it and it agglutinates. This is how an agglutinate or clumping of blood would look like. And then you drop antibody A in it and it clumps. That means it has antigen A, or agglutinogen A. And then if you drop it again on the same blood, in another corner, you drop antibody B on it, and it agglutinates, it clumps together like this. Then what that means, you both have antigen A and B, and that's going to be blood type AB. This is a blood type AB. In this blood type here, the clumping or the agglutination happened only on A. Therefore, you definitely would have the antigen A here, and it did not have any agglutination on B. Therefore, it doesn't have any B. Therefore, this is blood type A. In this situation here, it did not have any agglutination on B, on A rather, and had agglutination on B. So this is blood type A. And the last one here, there is no agglutination on either A or B, and therefore the only blood type that would not carry any antigenic marker, no A, no B, will be blood type O. So in the lab, this is actually how blood type O would look like. Okay. So now we're going to get into diagnostic blood tests. The diagnostic blood test, which is your hematocrit and your, your other blood screening, okay? MCH, pretty much, or blood count is going to be part of your exam in the lab. And you will have to know how to do it. And I will explain, if I have to, tonight in our Q&A question. All right. You will have to know how, well, we're not going to be doing differential white blood cell count, but we are going to be doing, MCV, and we are also going to be doing a complete blood count and how to go about, not complete blood count, but red blood cell count. So what are these diagnostic blood tests? Well, differential or diff white blood cell count looks at relative proportions of each white blood cell and therefore would tell you what your problem is. If you have an increase in eosinophil, therefore the doctor will say, oh, what is the eosinophil supposed to be responsible for? Well, allergies, or maybe like also parasitic infection. So you must have one of these two. And further blood tests or further tests will confirm either one, right? That's actually the purpose of your diff or differential white blood cell count. Prothrombin time and platelet counts would assess how fast you are going to clot. So it assesses the integrity of your hemostasis. The comprehensive medical panel would be assessing blood chemistry profile. It checks the various blood chemical levels, and an abnormality will pretty much point to what is wrong with your body. It could be an indication of liver or kidney disorder. And then your complete blood count will check on the formed elements. The hematocrit is one of them, or possibly counting of the hemoglobin. That is now the end of our lecture on the blood. And we are going to continue after this with the heart.